Hi, doctor. I'm calling about this patient. He is short of breath. I'm not sure what to do.
Let's go. So as an intern, if you get a call from the nurse saying, hey, your patient is short of breath. So in this video, what we're going to cover is what should your mindset be as an intern to deal with a case of shortness of breath. So the moment somebody says shortness of breath, and say for instance your senior is somehow missing on day one. He or she was supposed to be responsible for you, but they've gone missing. And you as the intern is responsible for this patient. So the moment you hear shortness of breath, what should go into your mind is the question. So first step first is, again, since this patient is not crashing, you do have some time. I'm not talking about a patient who's having a rapid response. I'm saying the patient's got shortness of breath. So the moment you hear that, the first most important thing that you need to do is open the chart and look at the patient's history. Because history is going to tell you what is the most possible reason this patient is short of breath. So when you think of shortness of breath and you go through the history, what are some common conditions you would think of that could cause shortness of breath? Asthma. Good. That's a big one. Who else? COPD. Another big one. Heart failure. Now let's put it as fluid overload, and that could be because of heart failure, it could be kidney failure, or liver cirrhosis. So fluid overload is another big one as to why somebody is short of breath. What else?
PE.
A PE, right? If somebody's had a previous PE, are they taking the anticoagulation or not? That's another big one. What else? MI. If somebody's got coronary artery disease or an increased ASCVD score, they might be at risk of having an MI. And MI does not always have to present with chest pain. It can present with shortness of breath. So, important thing, you'll quickly read through the patient's chart. You open the HPI, look at the progress note, look at the previous diagnosis this patient has actually had to kind of get an idea of what possible condition this patient may have to increase the risk of them having shortness of breath. That's number one. So step one, what you need to do is do a quick chart review, and you are going to look solely at history. Okay, which seems pretty benign thing that you're going to do. Now, number two, this is where you can grow to become better than anybody else. This is how, as you grow through time, you start analyzing the smallest things in a much more deeper way. Okay, so what's the next important thing that you're going to look at in the chart? Once you see the history, the next mindset should immediately go to this. Vitals. You're going to go to the vitals. It could be recent, it could be previous, but the important thing is vitals, and vitals are going to tell you a lot of important information. So number two, what you're going to look for is going to be vitals. Now let's open vitals in here, right? So when I say vitals, what is important for you? What is relevant?
Heart rate, SpO2.
Okay, so
if they're on oxygen.
So you want to know patient's heart rate, okay? You want to know what the patient's oxygen is, right? What else? You said blood pressure, okay? And temperature. Okay, but I said shortness of breath.
Respiratory rate.
Right, very good. Great. Because when you say shortness of breath, obviously respiratory rate and your oxygen are probably the most important things, right? So whenever you think of it, you want to look at the chart to see if the patient is on oxygen. Is there a reason for the patient having oxygen or not, right? So oxygen is pretty straightforward. Now your respiratory rate becomes fundamentally the most important thing if somebody is shortness of breath, right? So your respiratory rate in these patients are going to be what? What would you expect it to be? 12 to 20 is your normal, okay. So in your patient with shortness of breath, would you expect your respiratory rate to be elevated? Yes. You expect it to be elevated, good. Because if you're in respiratory distress, your prime response is going to be to increase work of breathing to bring it in. But could you also have a low respiratory rate? Yes. And would that be still a sign of shortness of breath? Yes. Why?
Neuromuscular weakness.
Right. If somebody could have a neuromuscular weakness, or you could have a central reason. If somebody got an opioid, something that's causing central respiratory depression could also lead to shortness of breath. So respiratory rate being up is an obvious thing. But what makes you different is the fact that you think, you know what, the respiratory rate is in fact low, and that is also a sign of shortness of breath. So it's important for you to look at that and see which path it's headed, right? Because this is what makes it different. Everybody looks at something in very narrow-minded way. I want you to look at it very differently, okay? Next, let's look at heart rate. What about heart rate? So if it's hypoxic, good. If somebody's shortness of breath and you got a hypoxia, then you would expect your heart rate typically to go up. So tachycardia is going to be a sign of hypoxia, right? So somebody's shortness of breath, you would expect your heart rate to go up because you're becoming hypoxic, right? It's your chemoreceptor response in your body. Is your heart rate being high also indicative of something else? Or could somebody have shortness of breath because their heart rate is elevated? Say it's 120s, 130s.
If it's severely elevated, it will cause low circulation.
If you have low circulation, you would technically get more of a hypotension situation, not really shortness of breath. But think about it, if your heart rate is too high, could you have a tachyarrhythmia?
Yes.
Yes. If you have a tachyarrhythmia, such as atrial fibrillation, atrial flutter, SVT, would you have shortness of breath?
Yes.
Yes, you would. Why? Because when your heart rate is really high, what happens? Your stroke volume is going to go down, so you don't push much out. As a result, you're going to back stuff up. When you back stuff up, you're going to end up with pulmonary congestion. So anytime anybody's got a tachyarrhythmia, may it be sinus tachycardia, may it be atrial fib, may it be atrial flutter, so elevated heart rate could cause shortness of breath. So elevated heart rate seems pretty easy to understand that, okay, if the heart rate's high, I should be thinking about arrhythmias, right? And that could be one of the reasons why the patient is short of breath. What else should you think about when the heart rate is really high and the patient is not having any arrhythmias? Very good. Whenever you have a heart rate that's elevated, PE really comes into your picture. Okay? But there's still other things that you want to look for, but PE comes into the picture. What about a heart rate being low? Is a heart rate being low? Can that cause shortness of breath too? Yes, it can. Why would it? If the patient is bradycardic, would bradycardia lead to shortness of breath? Yes, it can, because if your heart's not going fast, right? What do your patients complain about? Whenever I'm walking, they get short of breath. Because your heart rate is supposed to go up whenever you exercise. Why? So you can pump blood out, so you can supply oxygen. But if your heart rate is too low, you can still have shortness of breath. So you see, you can always have tachycardia or bradycardia. So your mind has to go into these places instantly. Okay? Alright. What about blood pressure? Would your blood pressure be high in shortness of breath? Would it be low?
If it's severely high, you can have pulmonary flashing.
Very good. So if your blood pressure is really high, meaning greater than 180 over 120, what do we call this? It's called
Pulmonary flash.
Flash pulmonary edema.
Hypertensive urgency.
hypertensive,
Emergency.
emergency or urgency. Was there a term called malignant hypertension previously, which was coined back in 1920?
Back in the day,
Yes, there was back in the 1920. Do we use that term anymore?
No.
Why not?
because we have medications.
Because you have medications to treat hypertension. Back in the day in 1920s, you didn't have blood pressure medicine. If your blood pressure was above 180 or 120, you were toast. Had a malignant prognosis. So they coined the term malignant hypertension for that reason. Now, if it's greater than 180 over 20, you have two choice of words. You can either call it hypertensive urgency or emergency. What's the difference?
End organ damage.
End organ damage. If it is emergency, you must have end organ damage, and that's not presence of a headache. If I have a blood pressure of 180 or 120, I too will have a headache. Does not mean I have a stroke. When I say end organ damage, it has to be objective evidence of end organ damage in the brain, such as
Encephalopathy.
encephalopathy, hypertensive encephalopathy.
Confusion, AKI.
You will have an acute ischemic stroke, hemorrhagic stroke. You can actually have an MI, you can have acute coronary syndrome, you can have acute pulmonary edema. So you have to have end organ damage. So technically speaking, if you had a hypertensive emergency which resulted in acute pulmonary edema or an ACS or an aortic dissection, you could have shortness of breath. So that's why hypertension is important for you to see. Now, important thing is when you have aortic dissection, you will have a discrepancy between both arms. So you want to think about that as well. Okay. What about hypotension? Would hypotension cause shortness of breath?
Yes.
Infection, pneumonia.
If someone is hypotensive, you become somnolent. You can have decreased blood flow to your brain. You can have patients with decreased responsiveness, decreased respiratory drive, and therefore they can become shortness of breath too. What about temperature? Question is, do you have a fever or are you hypothermic? Both are going to be important signs of what?
Infection.
Infection, right? So if your temperature is up or down, it could imply infection. And could you have an infection in your lung that's causing shortness of breath? Yes, such as what?
Pneumonia.
Pneumonia. But now that we've gone through a pandemic, we can think of COVID. You can think of influenza. A lot of viral infections can also cause viral pneumonia, right? Which can lead to shortness of breath, but they will always have fever. Remember, hypothermia is equally as important sign of infection as fever is. Okay, so you do want to look at the patient's temperature to see, hey, the patient's got a fever or hypothermia. Could this patient have an infection? May it be viral, may it be bacterial. But that's how you're going to assess your vital signs. So when it comes to vital signs, your thought process needs to go to all these places. Start making connections and thinking in your head on every single case. If it is relevant enough, then you will start training your brain to think about everything else. The other most important thing if somebody's shortness of breath is what? Is going to be, what is your patient's oxygen? That's what you want to know. Now, how are you going to assess what your patient's oxygen is? Typically. Pulse oximeter, right? You put a pulse ox on them and you'll see what the patient's oxygen is. Right? Normal oxygen is what?
94 and above.
94 and above. Now, once starts dropping below 94 and getting to the lower 90s, you start calling this hypoxia. Right? So if the patient is hypoxic, that is going to be an important objective evidence that your patient is actually having a problem because of the shortness of breath. Shortness of breath technically is a subjective feeling. Objectively, you show pulse ox. Now, another important thing as an intern, you'll probably recognize this a lot. You tell the nurse, hey, what's the patient's oxygen saturation? They say, hey, I'm putting it on the finger and it shows me 70 or 60. But the patient looks fine. It doesn't look very bad. What are you thinking about in those patients?
No circulation.
Right. So you need to realize a lot of our patients in the hospital are going to have very poor circulation to their extremities. Okay? Or they're having something else that's making the fingers very cold. So oftentimes those patients will not have a good reading. So how do you decide objectively if that might be the case in your patient? You can feel the skin, but also there's a waveform. Whenever you look at your pulse oximetry, you will see a waveform. You must have a beautiful waveform on detecting of your pulse oxygenation. If you don't and all you're seeing is some erratic lines like this, it is not picking up good. So that's an important thing that people don't realize, but you want to look at the waveform. If you have a beautiful waveform like this and it shows you 70%, you're more likely to believe it's true. If it looks like this and it looks 70%, you're most likely to not believe it's true. So what do you do in that instance? You can change the location. Try not to go from distal extremities, maybe put it in the earlobe or put it on the forehead. These are more central parts of the body that's more warm, it's more perfused better, and will give you a better reading. But say you do that and still it's showing low, right? Sometimes, unfortunately, your pulse ox still might not read very well, okay? And you might have bad waveforms that you can't really judge for sure. So what do you do in those patients? What's your real, absolute, objective way to tell me what the patient's oxygen is? Okay, so you're going to say it is going to be an ABG. So this question puts the internet into a frenzy, okay? Question is if somebody is hypoxic. If you want to assess oxygen, okay? If you want to assess oxygen, do you want an ABG or do you want a VBG? You must get an ABG, okay? If you're looking for oxygen, you want an ABG, you want to know what your arterial oxygen is, okay? Normally arterial oxygen will tell you the patient's oxygen saturation up unto 100. If you look at your venous oxygen, the max it will go to is about 70. You cannot judge the patient's oxygenation with an VBG. You need an ABG. So ABG is always going to be your number one, okay? In fact, if you look at your COPD patients, when you want to put them on oxygen, right? What do you gain? What test are you supposed to get to see if they qualify for oxygen? ABG. You're going based on what? PaO2 of 55, right? An oxygen saturation of 89. What are they referring to is an ABG, not VBG. Okay? So ABG is your gold standard if you want to know what the patient's oxygen is. Also, if you want to know what a patient's AA gradient is, right? Because sometimes you have a VQ mismatch in patients. When you want to know your AA gradient, the small a comes from ABG. If you're looking at oxygenation, you need ABG. If you can't get an ABG for some reason, you can work with a VBG. But top of the list is always going to be ABG. Now, if you want to assess pH on a patient to see what the acid-base status is, VBG is fine. If you want to assess PCO2 on a patient, VBG is fine. But if anybody says oxygen, it has to be arterial. Got it? So start with pulse ox. If that's not giving you the answer, go for an ABG. Yes, it's more painful, but we need objective answers here. So you have to go for ABG.